Dear friends, experts, contributors to this discussion, it's a great pleasure and honor to welcome you. And on behalf of women political leaders, let me say that it's a really tremendously important activity and initiative to develop a toolkit around women's health through their life course, especially in the months and the 1.5 years that we have had. Health has been in front center of every discussion, if it was a professional or private one. And I think it gets to certain standard questions on health, which we probably in days before COVID would have had conversations on weather, but now it's on health, which just gives it an additional relevance in health as a topic. However, women's health is still very much in need of specific attention, catching up with other health areas that have been addressed and inequalities that are still existing in dealing with women's health are becoming more and more apparent, and the need to address them is also becoming more and more of an urgent task. And in this decade that we're living in now, we have the promise that this should be a decade for change. It's the decade of the Sustainable Development Goals, which should pave the way for a more sustainable and inclusive society. But also United Nations and the World Health Organization have declared this decade the decade of healthy aging to improve the lives of elderly, their families, communities. And in this decade of healthy aging, specifically with the efforts also of WPL to promote the Sustainable Development Goals number 3 on good health and well-being, and the Sustainable Development Goal 5 on gender equality. So in this context, WPL, with your support, your help, your insights, your expertise, is creating a policy toolkit so that healthcare systems can provide integrated services equally to men and women throughout their whole life course, and also to meet the specific needs that women have in their life course. Today's panel is led by Dr. Ngumi, and it's a great pleasure to have you here. She is a writer, thinker, and a member of the NEST Collective. And this NEST Collective is a temporary informal network of networks which focuses on groups of senior level leaders from government, business, philanthropy, and media to help and enforce this big UN women effort, Generation Equality, of which WPL is honored to be a co-lead. And as a moderator, Ngumi will help shed light upon women's health throughout the life course in guiding this conversation. And I'm very happy to hand over to you.
Thank you so very much, Silvana. Thank you for your lovely words. It's a pleasure to listen to you give context to the incredible work everybody on this panel has done. And it will be a pleasure to really listen to everybody kind of speak from their particular perspectives to continue to elucidate and push us forward as regards the policy changes that are urgently needed so that women's health can be improved through the life course. I wanted to do a little bit of a personal introduction. As Silvana has said, my name is Dr. Njoki, and I wanted to say that in my relatively short lifetime and spanning my stakeholder shift from patient to practitioner and back to being a patient while being a practitioner, I've watched the frame of human medicine shift from being hierarchical, doctor-focused, and male-dominated. I have watched the field both demean women as patients while deeply rely on the input of workers who are considered lower cadre for the kind of deep care work that is a crucial part of healing. I've also been excited to be a part of the decentralization effort to get more information out there to patients and to everybody who becomes a member of the public, catalyzed by information access online and on social media, which has revolutionized the care and management of both communicable and non-communicable diseases across generations and demographics. This spread of knowledge via word of mouth and the quick, deft changing minds and the asking of reflective and insightful questions has been irreversibly led by women. I think it's time to call for a much more systemic and much more community approach, and it's really going to be beautiful to hear about this from all of our panelists today. It is important that we define what the community is. When we say that change will only come for us, by us, what does that mean? Who are members of the community? Which stakeholders have what kind of access? The idea of specialized toolkits and nuanced policy approaches is particularly attractive here. It's important to make a distinction between who needs to take better part in education and who needs to take better part in decision making. Education must be for all, by all, with a specific intention towards debunking and eliminating stigma, while decisions about women must be made more and more by women and for women and evaluated by women. It's important to continue to have flexible approaches that are people that are participated in by people and that are led by people, such that the people are the only ones who can give feedback about what is working for them and what isn't, and that new policies can continue to shift in the ways that they are best suited for the good and the ultimate health of the public. It's really, really lovely to have each and every single one of our panelists, and I'd like to start by introducing them all. I'll start with John Beard, who is a professor of the ARC Center of Excellence in Population Aging Research and in the University of New South Wales. He has worked globally with academia, policymakers, and the private sector to reimagine the second half of life. It will be really interesting also to hear from him what they have learned about what makes a city aging friendly. I'd really like to introduce Mariana de la Roche, who is the managing partner of operations and compliance at Madami. Mariana has a background in law and is currently doing an executive master in public administration. She is specialized in project management, human rights and humanitarian law, and has been working as a lead manager and consultant for different agencies, NGOs, and is particularly interested in menstrual health. It'll be good to hear from her about menopause. We are excited to have among us Melissa Gong Mitchell, who is the Executive Director of the Global Coalition on Aging and the leading business voice on aging policy and strategy. She's also the Managing Director at High Lantern Group, which is a strategic communications firm. It'll be exciting to hear from Melissa about the private sector and the places that they are making room for the aging populations. We are also excited to have our last but not least member of our panel, who is Xavier Prats Monné, who is the Senior Advisor for Strategic Initiatives of the Open University of Catalonia, Director General for Health and Food Safety, the European Commission. He's also the Special Advisor for Teach for All, which is a global nonprofit organization whose mission is to expand educational opportunity around the world, and also the Strategic Advisor of several other very, very worthy initiatives. It'll be really interesting to ask you all what the first question is, which reads like this. Interviews with health experts from the WPL network have underlined a common denominator, which is the call for communities to be involved since they play an essential role in enabling the provision of women's health services and health education. What leadership roles must be ensured in a community so that women have access to quality healthcare throughout their life course, from childhood all the way to mature age? And the second part of the question reads, what tools does every community need to empower women and girls with their own health? It would be lovely to start with you, Mr. Beard.
Thanks, Njoki. As you said, my interest is in the second half of life, and what we see as people age is an increasing diversity of health status and of social circumstance. So that there are some people in their 80s who have the robust health of a 60-year-old, and you have some people much younger who require considerable care and support. The interesting thing is where you sit on that vast range depends very much on what happened earlier in life. And so what we see is the cumulative impact of social position across people's lives, so that the people with the best health are those who've had the most advantage, and those with the worst health are often those who have the least resources with which to meet those needs. And what we see from research is that across that second half of life, women tend to have worse health outcomes than men. And so this reflects things that have happened across their life course. And I think it's going to be interesting to focus on those, particularly reproductive issues, issues around the responsibility of women child caring and caring for older people, and the impact that has on them economically. But I'm also really heartened to actually hear people in this meeting talking about older women, because what's tended to happen in the past is the needs of older women specifically have been neglected. When I worked at WHO as the Director of Aging, the Assistant Director General I worked with, Flavio Bustreo, had this terrific saying, which was that women are more than vessels of reproduction. And I think as we look at health of women across their life course, we tend to focus on reproductive issues. And of course, these are really important and subtle, and we need to think about them differently. But we also need to consider what happens to people, older women, and the issues that they confront, and the poorer health that they're experiencing at the same time, where they have these reduced resources in terms of meeting those needs. So in terms of the community, I think that the real support that the community can provide in terms of training women, in terms of perhaps taking on more of the caregiving responsibility rather than just assuming that women will do that, and with the negative consequences it has, and also looking at ways to ensure that older women can actively remain participants of their community and can continue to contribute in all sorts of diverse ways, and can continue to live lives of meaning and dignity. So I'm sure other people will touch on some of those earlier stages of the life course, but I just want to reinforce the needs of older women.
Thank you so much, John. That's incredible. It's important, especially to realize that not only does care work have a cost immediately on the economic lives of women, but it has a cost on their lifespan. This is really important to realize. Mariana, it would be lovely to hear from you as regards the leadership roles that must be ensured in a community for access to quality healthcare for women, as well as the tools that each community needs in order to empower women and girls for their own health.
Thank you, Dr. Njoki. I would like to start by saying that empowering communities start with education. So we need to facilitate access to quality information for women to make informed choices about their health. But we also need to understand the realities of the living context in which they live, and the different factors which impact the health decision making. And those factors, as they were mentioned before as well, are biological, economical, social, and cultural or environmental. So regarding education, starting with empowering girls to have control over their own bodies is the first step for them to have more agency across the life course in terms of their relationship, their potential careers, and the communities itself. We see menstrual health as the entry point to women's health, and therefore more education around menstrual health should be a must. As an improved understanding of the menstrual cycle and ability to manage their needs can potentially increase women's ability to manage their reproductive health needs. This includes having better selection of the use of contraceptions, reducing unwanted pregnancy, and early identification and treatments of menstrual disorders, for example. We need more women designing, delivering, and leading both educational and healthcare services to ensure that they are gender sensitive. So at the end, what we need is access to more accurate information and reliable information, role models on those communities, and community champions that can lead the change in those communities, and accessible and affordable health services for the women. Thank you.
Thank you so much, Mariana. It's been really important to hear about the really important role that menstrual health and reproductive health play in the lives of women throughout their life course, and the fact that every single person in the community, not just women, needs to take on this knowledge. Melissa, let's hear from you as regards these tools and the leadership roles in communities for quality healthcare for women.
Thank you, Njoki. And thank you so much to WPL and Silvana for your leadership. The fact that we're having this conversation today is really a great start, and the toolkit is a fantastic set of tools that I think are going to be able to be shared really widely through this network. So thank you for that leadership. I'm going to build on some of the topics I think really that John talked about. We focus on, at the Global Coalition on Aging, the opportunities that are associated with aging. So to take this sort of doom and gloom fear about the concept of aging and recognize that with longer lives, there's also the opportunity for healthier, longer lives. But that means, and that also means productive and fulfilling longer lives. But this can't happen without real changes in terms of driving innovation and challenging systems that have been structurally ingrained for decades or longer. So many of these structures disproportionately affect women, healthcare, workplace and retirement, childcare and elder care, for example. So as we address these issues, it's clearly about addressing gender equity as we address age equity, and recognizing that with longer lives, we have to address them differently. We can't continue with status quo. And as Silvana mentioned, there's some key milestones for leadership here, not only WPL's work, but last year, we celebrated the 25th anniversary of the Beijing Declaration on Women's Rights and the 10th anniversary of the formation of UN Women, and the Decade of Healthy Aging, which launched just at the beginning of this year, is very important. And especially recognizing that women's life expectancy extends longer than men's. Women bear the brunt of caregiving responsibilities for children, and increasingly for older loved ones, which is only increasing with the aging of the population. And then when you combine all of this impact over the lifetime, there are physical health, mental health, and financial health implications that affect women differently and for longer. And this is woefully underaddressed. And it does call for real leadership and action. And looking at this economically and sort of what has happened in history, these are the same women now who had dealt with fighting for childcare in the workplace 30 years ago, and now they're faced with making decisions about staying in the workforce or leaving to care for an aging loved one, and that takes away from lifetime earning potential, and women already earn less and while we live longer. So we're seeing this uptick even before the pandemic, and we're seeing sort of the interest in this topic and the recognition of it. We know that 60% of working caregivers, again, mostly who are women, say they leave work early, they come in late, they turn down promotions or leave the job to care for loved ones. And we saw these decisions being made too often during the COVID-19 pandemic, mostly women and related to childcare. And it will have a really grave impact economically overall. So, to your question about leadership, I think if thinking about it from this point of view and from a business point of view, from an employer point of view, employers really have an important role to step up to this new normal, as well as the healthcare system. And of course, global leadership we see through the SDGs and now the Decade of Healthy Aging launching. Those are going to be really critical catalysts. And some of these points were addressed in a report that we launched just last year here at WPL as well. And so hopefully that can be helpful as we look at these global milestones and what some of those tools can be, and particularly for policy, which I know we're going to talk about a little bit later.
Thank you so much, Melissa. It's really been great to hear you speak about losing the kind of doom and gloom approach, while also kind of keeping our feet firmly on the ground as regards the truth that women earn less and live longer while having to take care of everybody. So the inequity is strong very much from the beginning, and it's really important to have policy interventions that address this head on. Xavier, it would be great to hear from you as regards the leadership engagement, as well as the tools needed to enable women to engage the way they should.
Thank you. It's really a privilege to join this conversation, although I realize that being the last to speak, I am at high risk of mansplaining at this point. But let me say very briefly, on leadership, I would say something simple. The most effective and quick policy recipe is to put more women in position of power. Women are everywhere in the healthcare sector. In high-income countries, they are a majority of the health workforce. In low-income countries, they are at the heart of family care, which is the only care in the country many times. It's just that they're not in the driving seat. So if you want to do something quickly to make sure the communities care about women, the only thing you have to do is to make sure by positive discrimination, by quotas, make sure that more women are empowered. On the issue of tools, one thing I think is really important is, and again, this is I think mansplaining, because I think that Dr. Ngumi referred to it, involving women in the collection of information and in the design of health programs is extremely important. If you want to make sure you get it right on women's need, the best thing you can do is to listen to women. For example, through peer interviews, validation workshops. It is really very important to address the right needs with the right people. And then, since aging women has been mentioned already, let me say something about younger women. I think that policymakers often underestimate the strength and the potential of using digital platforms and increasing digital literacy. The truth is that young women especially, but women in general, even in low-income countries, actually use digital platforms to access information. That doesn't mean they have easy access, but they use it, and they use it frequently. It's just that they have a difficulty in obtaining information, and they have a difficulty trusting that information because they don't know whether it is reliable. So I think it is important to make sure that there is accurate information easily available in digital platforms, and to link online health information to youth-friendly medical and community services. There's an extremely interesting study done by Women Deliver and Girl Effect, two extraordinary interesting NGOs in India, Malawi, and Rwanda, that actually show precisely this, the importance of making it easier for women and for young women to use reliably digital platforms to get better information, especially on sexual and reproductive health.
Thank you so much, Xavier. Your points are really strongly aligned with Mariana's as regards making sure that people have information that is really easy to access and that it's also easy for them to trust. And that's really important because everybody is always telling young women, turning them away from the information they need, using moralistic approaches to tell them that this is not what you need to know, go and study or go and take care of somebody, as opposed to taking care of themselves. Thank you so much for pointing that out. And thank you also for your focus on older women and bringing incredible balance to this conversation. Our second question has to do with the proven gap in women's health research and data collection. And so the question has a few parts. What has prevented data from including women before, and how can we shift from this difficult focus? How can research that is disaggregated be incentivized? And how can data be then aggregated and gathered to fully cover women's needs? Let's start again with you, Mr. Beard. How can we shift from this focus that has continually invisibilized women? How can we incentivize disaggregation in the collection of data? And then how can we aggregate in a way that fully covers for women's needs?
Okay, well, I think the answer to the first question partly goes back to what Xavier was saying, which is that we really need to involve women in framing the questions, because if you don't identify the need gaps, if you don't identify the critical questions that are important to women themselves, then you're not going to have worthwhile data to start with. So I think we go there to start. And that reflects, I think, a complete undervaluing of some of the issues that are important to women over the years. So I think that would shift the data collection. It's amazing that most data currently actually does include in the data set the sex of the person who's interviewed. But then when it comes to the analysis, so often it's just aggregated between the two sexes, and we lose incredibly nuanced and important information by doing that. So the first thing would be to make sure that people use and disaggregate the data that then does exist. And not only do we do that by sex, but we also do it by age group. And we don't stop at, say, 60 plus. We keep going in 10-year, for example, age groups across the whole of the life course, because the experience of women at those different life stages is going to be quite different, and we need to be able to disentangle that as well. How do we incentivize it? Well, I think the funding agencies carry some responsibility. It's not hard for funding agencies to require data to be collected and disaggregated by sex. It's not hard for them to require some sort of involvement in women in the development of questions. And it's certainly not hard for them to require reporting which considers disaggregated data. And the same can be said for policy institutions, international institutions like the World Health Organization, or governments, or whoever it is. they also should require things to be disaggregated by sex. And it's incredible what you can find when you do that. For example, with common issues like heart disease, you will find that while the incidence is actually not that different between men and women, because clinicians tend to not think that heart disease relates to women, they don't test it and follow it up as well, and so they don't receive the care that they require. And if you disaggregate the incidence data and the data for care provision, you'll actually see that disparity. So I think it's very doable, and I think it just comes back to funding agencies and policy agencies.
Thank you so much, John. And you've actually made me remember that with heart attacks in particular, they manifest very differently in men and women. And very, very often, women are not diagnosed as having heart attacks, even when they have, which already starts them off on a wrong diagnostic path, and will also skew any data that's collected later, because when she goes home and is asked, do you have a heart problem? She'll say no, because somebody said she had another issue. So that's a really, really important point to raise. John, thank you so much. Mariana, let's hear from you as regards the incentivization of this data, and what, in your opinion, can be done to stop this gap from existing as regards women's health research and data collection.
Thank you. So I think that the main problem is that when we talk about women's health historically, it has been always focused on women as the incubator and predominantly only in the role of potential mothers. So a lot of the assumptions that we have about women's maternal and caregiving role is baked in how we do research, how we design services, how we talk about health focuses on pregnancy and postpartum care. So we all know what happened with the WHO last week, where by a miscommunication in the release of their draft global alcohol plan, I think that was the name, I'm sorry, escaped my mind. They suggested that women of childbearing ages, which includes women between 18 and 50 years old, should abstain from alcohol to protect their fertility. So we need to move away from thinking about women's health and their sexual and reproductive rights just for the fertility, pregnancy, and postpartum health point of view. But we also need to stop seeing women's health only for the reproductive purposes and go beyond women's reproductive role in society, as well as we need to think about women's health more holistically and the variety of unmet health needs that goes from fibrosis, female cancer, and menopause. So women's pain is minimized, is mistreated, and more than men's, and we need to start asking ourselves why. So to close this gap, and I think that I will echo a little bit what Xavier mentioned before, is we need to set in quotas for researchers to ensure more research is conducted by and for women, as well as racial and ethnical minorities. We also need to have regulatory and mandatory minimums in place, which guarantee that women are involved in all clinical trials where women may be impacted. And we also need to increase the available funding for underserved populations and their health issues, not only for research, but as researchers themselves. So take, for example, what happened with the COVID vaccine. We honestly have no idea how this vaccine will impact women's menstrual cycles. How could that not be taken into account when we are developing a vaccine for half of the world population? So we know right now for anecdotal evidence that this vaccine has demonstrated is causing heavy bleeding, more severe symptoms, and painful periods overall. But however, attempts by researchers to explore this issue further is severely underfunded, as was expressed this week, at least here in Germany, for the different research institutes. Thank you.
Thank you so much, Mariana. You've also reminded me of the ways in which young girls, especially, are dismissed whenever they have symptoms of illness. They're often told they're lying, they must be faking. There's often a lot of punitive approaches to women and the symptoms that they have. It reminds me also of a reality show where people enjoy watching very young women realize that they're pregnant very, very late in the game. And while the shock factor can make for very good TV, it makes for very alarming public health approaches. So thank you so much, Mariana, for talking about this. Melissa, let's hear from you as regards what the gaps in the data are and where you think these gaps can be filled in.
I think it starts by really understanding, looking at the numbers. We need to sort of see what it's showing us and know that more research is needed. So I do think it's, again, sort of back to the equity point, understanding that cardiovascular disease is still the #1 killer of women in the US. In terms of brain health, 2/3 of patients with Alzheimer's disease are women. They also have those caregiving responsibilities again, but in research, 2/3 of the animals that are researched are actually male. Autoimmune disorders, 78% of Americans with autoimmune diseases are women. And so we have to look at all of these health implications that we're learning about and realize that the research needs to point in that direction. So as we're looking at recruitment for clinical trials, and as has been discussed, Mariana, you mentioned, and Xavier, in terms of making sure that women are part of this research and that we consider the impacts of women of childbearing age is critical, and it's been critically absent also from that. And I think in terms of empowerment, in terms of the data, I think there's one thing to make sure that we have all of the data, but I think for an individual to ensure that they are in control of their own health data is really important, because particularly as it's related to the aging of the population, it's important for us to know sort of what are the risks for certain comorbidities. As we know, we're more at risk of certain comorbidities as we age, and therefore there is higher potential for medications, and so there's higher potential for polypharmacy. So we all need to have sort of a recognition of that. And as we prepare for a healthy aging process, I think looking at what are the opportunities for personal health records, we're seeing that in countries like Israel and Denmark, in terms of people really owning their own health data, and in many cases, their financial data in one place. And again, with aging, I think it's very important that we have those opportunities, we have those systems in place, but that people can also have ownership to empower themselves as decisions, so they can be engaged in those decisions. And then in terms of how to incentivize and think about why we should be making these changes and really focusing on women, there's a report from Women's Health Access Matters. Their acronym is WHAM, and their focus is really looking at how do we increase research on women's health issues. And their first report that came out looked at Alzheimer's disease, because we're seeing, all these disparities in diseases that increase in prevalence with aging and that are more prevalent in women as well, like osteoporosis, for example. But with Alzheimer's, and what the WHAM report showed is that Alzheimer's research focused on women could generate 224% in economic returns. So that's 15% more than general research. And doubling the funds for women's Alzheimer's research would pay for itself 3 times over. So investing $300 million for women's Alzheimer's research would give back $930 million to the economy. And so they did this economic research with RAND. It's really interesting to see. We need to start looking at this data, understanding sort of what those impacts can be. So I definitely think more research is needed, and empowerment for individuals.
Melissa, I strongly resonate with everything that you've said, and I want to draw special attention to what you said about polypharmacy, and it reminds me very much of the ways in which women tend to know the health details of everybody in their household. So the woman knows everybody else's polypharmacy, all of the kids' allergies, the husband's litany of medicine, and then when you turn to her, actually nobody knows what's happening with her. And so when something happens to her, everybody is sent into a panic, because it's very clear that she was carrying all of her issues alone. So thank you so much for bringing that up, especially as regards the risk of polypharmacy with aging and the need for people to own their own personal health records, where if the family got involved in their own health much more, of course, with a view towards nuanced involvement, it would take a weight off of the care work that women do. Let's hear from you, Xavier, as regards this data gap and the ways in which it can be plugged with policy.
Yes, thank you. Well, there's 2 kinds of systemic problems, right? One is unconscious bias, and the other one is simple neglect, which is of scandalous proportion. I mean, take, for example, endometriosis. I mean, it's a condition that affects possibly 1 woman out of 10, although precisely we don't know exactly. And the amount of money spent on research on this is infinitely less than, say, diabetes, which affects fewer people than endometriosis. So there's really a serious problem. The good news is that, as I think in general for women's health, it's easy to solve in a way, because it only requires political will and policy decisions. So what I would say for research is actually pretty simple. It's a matter of priority setting, policy priorities, and monitoring. So priority setting when you start research funding, straight ex-ante conditionality of research funding, for example, formal requirements that data are collected with a gender perspective, disaggregated, the gender perspective in the ex-post evaluation and the assessment of research projects and their evaluation, the adoption and implementation of protocols, checklists, for example, to avoid unconscious bias in the setting up and implementation of research projects, and again, more women in decision-making positions on healthcare. Because again, women are everywhere in research, except not when it matters to decide policy priorities.
Thank you so much, Xavier. You're right that women are everywhere except where decisions are being made. That also resonates strongly with what John had said as regards putting women in the driver's seat. They're already driving so much, but it's like they're driving from the side. And if they were really allowed to do the things that they need to do, the changes we could see could be astronomical. We're actually on the verge of our last question, and I want to congratulate you all for making all these important contributions to this wonderful conversation. And our last question is that people who are interviewed agreed that there is no one-size-fits-all health policy toolkit that can help improve every single woman's health or every community or every national health system. So what sort of context is needed to be considered when drafting these policy recommendations, which is the never-ending question between when can you be nuanced and when do you take a much more blanket approach? And how gender-specific must universal health programs be in order to positively impact women's health through the life course? Let's start with you again, John.
Okay, so I think there are some obvious issues which really confront women either exclusively or much more than men. So you've got all the reproductive issues we've talked about, then you've got the sex-related cancers, breast cancer, cervical cancer, ovarian cancer, and so on, and a few other conditions. We need to make sure that those are equitably resourced, and that doesn't necessarily happen. And then there are other issues, for example, endometriosis, which clearly doesn't get the funding which it's due, and same with issues like osteoporosis and other conditions. But what I'd like to touch on too that are somewhat more neglected. When we say not to think about one size fits all, I think that is the future. Medicine is moving more and more towards personalized care. Each of us are different. I'm not just a man and some other people are women, but we are all different within our genders. And we need to be able to understand the impact that those differences have on different forms of care. So for example, a drug may work much better in women than in men or vice versa, but at the moment we're actually not looking at that. We're thinking of the drug and everybody without that sort of nuance. And I think as we move forward, that's going to become more and more important. The other thing I really want to touch on and emphasize is, as you think about healthcare, you also have to think about social care and people towards the end of life. And I'm thinking here particularly about Alzheimer's disease, which is much more prevalent in women than in men. There are some places in the world, in Africa, for example, where if you are a woman and you develop Alzheimer's disease, you're treated as a witch, sent to a witch's camp or chained to a tree for the rest of your life. That is simply not acceptable, and we need to be developing much more comprehensive systems of long-term care that are applicable in low-income countries, but where women, regardless of their health circumstances towards the end of life, can experience a life of meaning and dignity. And I want to make sure that that doesn't slip off our agenda.
Thank you so much, John. It's really great that you've brought up the ways in which people with cognitive impairments are discriminated against and particularly harmed and violated, which really links strongly to the ways in which we approach mental health actually across the entire life course, because you find that people living with disability and those struggling with mental health challenges face similar disenfranchisement. Thank you so much. Mariana, let's hear from you as regards where do we find nuance, and is a one-size-fits-all approach really going to go with us into the future?
Thank you. So we all heard about human-centered design. That is like now a design methodology applied for like many of the different solutions and products that are out there. But the problem with this methodology is that men is often the placeholder of human. So we at Madami, we're creating a new methodology that uses human-centered design main concepts, but applies gender lens to the design process. And we call it women-centered design. So we use this methodology to understand that being born female means that you will have specific health concerns over your lifetime. However, these health needs and the health decision-making is driven also by gender patterns and dynamics within the social cultural context in which women live. So we work with researchers, innovators, and policymakers to develop truly gender transformative solutions, understanding women's biological needs, the social context in which these women live, the economical capacity and purchasing power they have, which will impact their ability of access health services and products, and the environmental factors and infrastructure they will have access to. So we connect all of these experiences across the life cycle so we can design solutions that support them to respond to their needs from menarche to menopause and beyond. So echo a little bit like what John said, there is no magical recipe that works the same for each woman in every single context, but understanding women experiences and the needs they actually have, we can at least customize those solutions better than ever before. So right now we live in a world that is a gendered world. So we need to start designing gender policies and healthcare system which can serve people real needs. At the end, it's not just about designing for women, but actually creating gender transformative and more inclusive healthcare for all of us. Also, I think that as the part of the education, like we can not only base in like educating women, we only need to educate like healthcare professionals and policymakers. And there are already international instruments in place, but most of them are unknown to the people that should use them. So if we take as an example, the Minsk Declaration, which was ratified in 2020 by more than 15 countries, the Minsk Declaration was a specific commitment to strengthen the life course approach of public policies and services when talking about health. And I would like to actually see how many of these countries implemented this at the country level. And what these kind of declarations and international regulations are doing is like giving the opportunity at the country level to generate policies that actually materialize those commitments into action that can impact the public health system. However, it is not enough to create a good piece of policy, as some of you already mentioned, but we also need to think about the accountability mechanism and how to train our health practitioners. I think there was Xavier who mentioned that gender bias are unconscious bias and they're everywhere. So we also need to educate the patients to know their rights and support them to navigate the health system better. So in addition, if they know how the instruments and policy works and their rights work, they can hold their governments and health institutions to account. So I actually believe that when women's pain stop being ignored, minimized, or misdiagnosed, then maybe and only maybe we can start rebuilding trust on those health systems.
Thank you so much, Mariana. It was really important for you to raise this issue of a multidisciplinary approach where you have to get multiple people to the table and to do very, very deep dives into the gendered nature of all of the problems that we have to solve. And absolutely, as regards healthcare practitioner bias against women, which is almost inculcated completely at the medical school level and at the healthcare learning level. And that actually is a thing that needs to end post haste. Thank you so much. Melissa, let's hear from you.
Yeah, I think I can echo some things and then talk about some new things that we're learning from a GCOA perspective. But I think this concept of making sure that care is certainly integrated and care is personalized. And I think that goes from every spectrum to healthcare to long-term care. And I think those really need to be focus areas because it can't just be simple sort of tick boxes in terms of how we adapt care, but understand how all these conditions and how medications and things, how interact with each other. So I do think that's going to be an important understanding in terms of how we change healthcare system, how we change training for healthcare professionals, which is really important. But I think on that personalized side, today we're actually launching a new white paper, and we focus on a proactive approach to healthy aging. And we looked into the role of inflammation control and integrated care. So to the point of, is it personalized? How do we look for the underlying conditions that are going to affect us as we age? And in many cases, and what we found here is that many chronic inflammatory diseases do affect women differently, and of course are engaged in terms of how a treatment path can be put forward. If a woman is of childbearing age, should she continue her medication for chronic rheumatoid disease, or should she continue that? Because is she scared that the medication is going to affect her baby, or is she more scared that getting off the medication and the impacts of the disease are actually going to have more impact on her baby? And then that has impact over a long period of time throughout her life course. So I think, as we have this longevity, we also see non-communicable diseases, including cardiovascular disease, cancer, chronic respiratory diseases, dementia. We've talked about a lot of these, osteoporosis, and others. Those are accounting for 71% of all deaths globally, and they create really an immense burden on morbidity and disability, and they reduce quality of life, independence, social connections, and reduce functional ability. And so the challenges there become not only health challenges, but social care costs, as we talked about, lost productivity in the workforce, and burdens on families. So when we look specifically at this issue, this underlying issue of chronic inflammation, we can see that if we address that in the proper way and we target individuals to ask these right questions from a healthcare professional point of view, we can avoid progressive damage accrual and reduce the risk of comorbidities throughout a person's life. So this is kind of a new perspective that we think is important for how we evaluate health, and therefore a new way to think about policy focus. So we are calling for more attention to issues, including chronic inflammation, to how that can benefit maintaining functional ability, how we can respond better to these types of conditions in the healthcare system. And then look at those economic impacts as well. And we do see that women face a disproportionate risk for certain chronic inflammatory disease like rheumatoid arthritis, which I mentioned, and other comorbidities. So it is really critical that we look at it through this lens. So that's a way that I think policymakers should be looking at it, as well as healthcare professionals.
Thank you so much, Melissa, especially for raising that one of the underlying issues that faces women is constant worry, and a worry that they're actually carrying very much alone, having to negotiate between something so existential as your future childbearing career and your acute body needs now that have to do with your quality of life is a very heavy thing. And this is one of the things that communities should definitely step into helping. Xavier, let's hear from you as regards what the ways forward can be and what the future holds as regards integrated and holistic care.
Yes, I'm conscious of time, so I can be very brief. I think that the really important thing about the policy recommendations impact is who is going to implement it. So I think that one important aspect to consider when it comes to, for example, policy recommendations, including the toolkit we are discussing, is the capacity of the public health system. And I'll give you a very simple indication. Maternal mortality rate, which is a very basic but also very important indicator of the performance of a healthcare system. Even within Europe, you go from 3 deaths per 100,000 live births to 30 in some other countries. The world average is about 200, and in low-income countries about 500. Now that gives you a sense of the very different nature of challenges that different systems have. In the case of Europe, the biggest problem is actually priority setting. In developing countries, it's actually capacity building. So I think that when you establish a policy recommendation, the one key factor at least should be who is going to have the capacity, the task, the responsibility, the legislative capacity to implement those policies and act accordingly. Otherwise, many proposals, many recommendations may seem wonderful, but they may seem very, very far away from practice.
Thank you so much, Xavier, and thank you especially for being conscious of time. I think maybe to kind of recap all of the lovely, lovely things you've said, there's been a lot said about looking at the facts right in the face, as it were. The fact that women, for instance, earn a lot less while living a lot more is really crucial. It's really important to realize that it's almost been a design flaw that research has not had enough data as regards women. And so there's many, many things that people can do to roll this back, especially as regards holding the money hostage almost, in a sense, until everybody agrees to just kind of move the ball where it's supposed to go. And thank you so much, everybody, for talking about the need for personalized and nuanced care, which will not only help women across the life path, but will also help men along their life courses, because everybody will be definitely served by a nuanced approach. Thank you all of you for your lovely contributions, your deep commitment to making sure that these policies move forward. Thank you for asking the tough questions. And thank you, of course, for being committed to sharing all of this information, doing all of this research and sharing all of these reports. We look forward to hearing from you continually as we go on this journey together. Thank you so much, everybody, and have a lovely, lovely afternoon.
Thank you. Thank you, everybody. Thank you.
Thank you.